Welcome to Pharmacy Friends. We bring industry experts to the same table to talk about what is happening in pharmacy today, what is coming, and most importantly, what it means to you.
There's still a lot we don't know about these drugs, including long-term efficacy and safety. So I'm looking forward to more real-world experience with these drugs. I can't stress enough how important lifestyle and behavior changes are and how big of a role they should have in weight loss and weight management. Social media has played a huge role in this boom we've seen in interest in GLP-1s.
And I guess it's important to manage patients' expectations, remind patients that these drugs are not a magic bullet on their own.
Yes, and I'll just add that, I think by providing real-world data, pharmacy organizations can improve weight loss outcomes.
A hot topic in the healthcare industry is GLP-1s and chronic weight management. In this first of a two-part episode, our experts discuss clinical evidence, drug information, and appropriate patient selection for GLP-1 use. Hosting today's episode, The Skinny on GLP-1s, is Maryam Tabatabai, Vice President for Clinical Information. Joining her are two experts, Olivia Pane, a clinical pharmacist at Prime Magellan RX, who is also a certified diabetes care and education specialist by helping manage and treat diabetes, weight gain, and other chronic conditions, and Carole Kerzic, a drug information and pipeline clinical pharmacist at Prime Magellan RX, who has extensive expertise following emergent therapeutics and investigational drugs from pipeline to post-FDA approval. These experts discuss the role of lifestyle modification, upcoming drug pipeline decision, and even tackle how celebrities and social media influencers have impacted the availability of these medications.
Hello and welcome to our podcast. I'm Maryam Tabatabai, Vice President for Clinical Information at Prime Therapeutics and Magellan RX Management, and I'm your podcast host. Today's hot topic is GLP-1s and chronic weight management. So our purpose at Prime MRX is to provide the care we would want for our loved ones. And what my team and I do is use evidence-based medicine and our drug information skills to provide the most clinically relevant information for our clients and patients we serve. With that in mind, I'm delighted to welcome my guests and two of my colleagues, Olivia Pane and Carole Kerzic. Olivia Pane is a drug information clinical pharmacist. She has practiced in a family practice setting in the clinic, managing patients with diabetes, weight gain, and other chronic conditions. Olivia is a certified diabetes care and education specialist. She is an American Society of Health System Pharmacists Wellbeing Ambassador, and Olivia is also a National Academy of Sports Medicine certified personal trainer. Welcome, Olivia.
Thank you for the wonderful introduction, Maryam. I'm happy to be here, and I'm looking forward to our discussion today.
Great. Carole Kerzic is a drug information and pipeline clinical pharmacist. She has extensive expertise with emerging therapeutics and follows investigational drugs from pipeline to post-FDA approval. Carole is the executive editor of the Prime MRX quarterly pipeline publication. Welcome, Carole.
Thank you, Maryam. I'm happy to be here today. This is an exciting topic that we'll be discussing.
Well, I'm really grateful to have you both here with me and excited to have this conversation together. So let's dive in. Olivia, maybe just to level set, tell our listeners how GLP-1 drugs work. We've heard so much about them, but I'd really like to kind of have that baseline understanding.
Absolutely. So GLP-1 stands for glucagon-like peptide 1, and this is an incretin hormone, or sometimes you might hear it referred to as a gut peptide. And we all produce GLP-1 naturally in the small intestine. So the GLP-1 receptor agonist medications bind to GLP-1 receptors in the body to trigger the same effects as naturally occurring GLP-1. So those effects include signaling the pancreas to release insulin whenever blood glucose goes up after a meal, blocking secretion of glucagon, and also acting in the GI tract to slow gastric emptying, meaning it takes longer for food to pass through. And then finally, working in the brain to reduce hunger and promote satiety.
So, who are the players in this space?
Yes, so GLP-1s have been around for several years because they were first approved for treatment of diabetes. And some of the more commonly known injectables for diabetes include liraglutide or Victoza, which is dosed once daily. And then we also have dulaglutide, which is Trulicity. We have semaglutide, which is Ozempic. And then we have tirzepatide, which is Mounjaro. And these agents are all dosed once weekly. Now there's now a once daily oral formulation of semaglutide as well for diabetes, which is called Rybelsus. And the GLP-1s are big players in the diabetes space because they're now recommended as a first line option because of their efficacy in lowering blood glucose and producing weight loss, but also because of data showing cardiovascular benefits in diabetes patients.
Okay, so now that's the diabetes space. What about GLP-1s that are FDA approved for weight loss?
Yes. So a few of the GLP-1s have now been approved for chronic weight management. So we have liraglutide, which is once daily Saxenda, and we have semaglutide, which is once weekly Wegovy. And now we also have a new tirzepatide product, Zepbound, which is actually a dual GLP-1 GIP receptor agonist, or sometimes it's referred to as a twincretin. And Zepbound is a once weekly injectable, and it has the same active ingredient as Mounjaro, which I mentioned earlier for diabetes.
Got it. So you just mentioned that Zepbound has a dual action. We covered GLP-1s, but how do GIPs work?
Yes. So, like I mentioned, tirzepatide, which again is the active ingredient in the newly approved weight loss product Zepbound, is a dual agonist of both GLP-1 and GIP. So, the GIP part stands for glucose dependent insulinotropic polypeptide. So, like GLP-1, GIP is also an incretin hormone, and it also works to stimulate secretion of insulin after a meal. But non clinical studies suggest that when it's added to GLP-1, GIP may actually help complement the effects of GLP-1 to regulate food intake even further and therefore produce additional weight loss from what you'd get with a GLP-1 alone.
Okay, so Carol, as Olivia just mentioned, we have three injectable GLP-1s that are FDA approved for weight loss. We know that these are highly effective, but tell our listeners what was actually seen in the clinical trials. Let's start with liraglutide, Saxenda.
Well, Miriam, I'll start by saying that there were common features in the pivotal trials for the three agents. All three were studied in phase 3 placebo-controlled trials, and they enrolled patients with obesity or overweight and cardiovascular risks. Also, the studies were conducted in both adults with and without type 2 diabetes. And as part of the studies, participants were actually advised to follow a reduced calorie diet with a 500 calorie per day deficit and also to engage in at least 150 minutes of physical activity per week. So among non-diabetic adults, the SCALE program reported a 7.4% mean reduction in weight after 56 weeks with Saxenda 3 milligrams. And then the STEP study reported a 14.9% mean reduction after 68 weeks of Wegovy. And the SURMOUNT program reported a 20.9% mean reduction after 72 weeks using the highest dose of 15 milligrams of Zepbound.
So, are there any comparative studies then for GLP-1s, again, specifically for weight loss?
Yes. Novo Nordisk reported top-line results from their STEP 8 trial that compared Wegovy and Saxenda, and it reported a mean weight loss of 17.1% with Wegovy compared to only 6.6% with Saxenda. And then there's also the SURMOUNT 5 trial comparing Zepbound and Wegovy, and this study is ongoing and expected to complete in November 2024.
So I think by now, Carol, everyone has heard about the GI side effects with GLP-1s, right? But tell me a little bit more about these side effects.
Well, these GI-related side effects are common with these drugs and actually a reason for discontinuing them. In clinical trials, most common GI side effect was nausea, but it appeared that it may occur less with Zepbound than with Wegovy and Saxenda, as seen in studies that were not head-to-head, so comparisons should be done with caution. In addition, GI effects typically occurred at the start of therapy and with dose escalations, but these effects can be minimized with dose titration, which is actually recommended during the first 16 weeks of treatment. And in clinical trials, most GI events were mild to moderate in severity, but severity can vary between patient to patient, and severe events have been reported.
So I've also heard about hair loss with GLP-1s, and I'm curious, how big of a side effect is this?
In non-comparative trials, hair loss was reported in 4 to 5% of adults taking Zepbound and about 3% of those taking Wegovy. And this is compared to about 1% of those who were given placebo. And Zepbound's labeling also reports that hair loss occurred more often in females than males. And interesting, though, the incidence of hair loss isn't reported in the Saxenda labeling. But one thing that I want to mention is that a rapid decrease in weight in itself is associated with temporary hair loss that can last up to 6 months. And this has been seen with restricted diets or weight loss surgery, and may be due to a nutrient deficit as well as stress.
Very interesting. So something else that got my attention is suicide ideation here. Olivia, what do we know about this, potential safety signal?
Yes, Miriam. So this is an interesting and important topic in terms of safety, and it is one that's being investigated by the European Medicines Agency, or the EMA, because of about 150 reports of suicidal thoughts and self-injury in patients who were taking liraglutide and semaglutide products. Now, I will say it's too early to tell if these cases are associated with the medications themselves or underlying patient factors. But as of now, suicidal ideation is included as a warning in product labeling for Saxenda, Wegovy, and Zepbound. And it's recommended to avoid use of these agents in any patient who has a history of suicidal attempts or, of course, active suicidal ideation. And I'll also just mention that the EMA's safety committee will be revisiting this topic at their April 2024 meeting, and they will communicate new information once it becomes available.
Well, we'll certainly monitor the safety of GLP-1s and be on the lookout for any updates in that spring timeframe. So, Olivia, you mentioned Zepbound is now FDA approved. And by the way, for our listeners, it is also available in pharmacies. I guess I wonder, who is the competitor to Zepbound, again, when we're considering this weight loss space?
Great question. So I would consider Wegovy to be Zepbound's biggest competitor in the weight management space. So they do have the same indication for adults. They're both approved for weight management for patients with either obesity or with overweight and at least one weight-related comorbidity. But I will point out a difference here, which is that Wegovy is also approved for use in adolescents 12 years of age and older, whereas Zepbound is not yet approved for younger populations. Now, another big similarity between these two drugs is that they're both once weekly injections. So they do have that convenience factor in common of fewer injections compared to like Saxenda, for example, which is administered daily. And also, if we're looking at all of the current weight management medications on the market, excluding Zepbound, Wegovy has had the most impressive weight loss in its clinical trials in patients without diabetes. So, Carole already covered the data from the STEP trial series. And to just kind of put things into perspective a little more, Wegovy at its highest dose of 2.4 milligrams weekly produced an average weight loss of up to 34 pounds in its clinical trials. And with Zepbound at its highest dose of 15 milligrams weekly, the average weight loss was up to 48 pounds. So definitely some very significant weight loss was seen in trials with these drugs. And also, I'll mention that the results of the SELECT trial were recently published, which showed that Wegovy actually may have cardiovascular benefit when used for weight loss in patients without diabetes. Now, I do want to kind of close off this question by emphasizing that Wegovy and Zepbound have not been compared directly in a published head-to-head trial, so we do need to use caution when comparing their clinical trial results.
Yeah, so tell me a little bit more about Wegovy's SELECT study, right? That cardiovascular outcomes trial. Earlier, you mentioned that certain GLP-1s are cardioprotective, right, in patients with diabetes, but I'd love to better understand the evidence for SELECT in weight loss.
Absolutely. So, the SELECT cardiovascular outcomes trial included patients who have overweight or obesity and established cardiovascular disease, but who do not have diabetes. And it showed that Wegovy, at its highest dose of 2.4 milligrams weekly, reduced the risk of major adverse cardiac events. And that includes cardiovascular death, non fatal MI, and non fatal stroke by 20% compared to placebo. Now, this number reflects relative risk reduction and not absolute risk reduction. So the absolute risk reduction was only 1.5%. And I think it's important to highlight that caveat. Now, there are other limitations to the SELECT study that I think are important to mention as well. So, this was only a secondary prevention study, meaning that patients who were included had to have established cardiovascular disease. So we don't know if Wegovy has any benefits in primary prevention. And the mean duration of follow up in the study was about 3 years. And while some patients were on drug for nearly 4 years, we still need longer term data. And of course, it's also important to keep in mind that these data from the SELECT trial are from a study setting and they might not accurately reflect real world data.
There seems to be lots of emphasis on weight loss, but what about weight maintenance? I'm not really hearing as much about maintenance. And I guess, what about that notion of weight rebound, right? Patients start on the drug, but then stop taking medication. I wonder what happens when patients stop taking GLP-1s.
Yes, I think it's really interesting how so much emphasis is placed on weight loss. And while the weight loss piece is really important and takes a lot of effort, I think weight maintenance often gets overlooked. So, a patient has lost weight and has reached their goal. Now, how do we keep that weight off? And I would argue that maintaining weight loss is even more difficult than losing weight to begin with, because once weight is lost, a patient needs to be able to keep up those lifestyle changes that they made to produce the weight loss. And often the motivation to keep up with those new habits tends to dissipate for a lot of people. And if we tie the GLP-1s into this, so right now these are considered to be chronic medications, meaning that they should be used for long periods of time to help a patient maintain their weight. But of course, not all patients will want to take these drugs long term. And actually, a study of our claims data here at Prime Therapeutics and Magellan RX found that only 27% of members remained on their GLP-1 therapy after 1 year. And another recently published cohort study found that of all the anti obesity medications, including orals and injectables, people did stay on semaglutide the longest, but still at the 1 year mark, only 40% persisted with semaglutide therapy. Now, generally, what research is starting to show is that weight rebound does also happen whenever these drugs are discontinued. So, for example, there was a study published in 2022 which looked at weight rebound after patients stopped taking semaglutide. And it found that after a year, patients had actually regained 2/3 of the weight that they lost. And, I think this makes sense because the GLP-1s aren't really addressing the root cause of obesity. They're simply reducing hunger and appetite while a patient is taking the drug. And also, when any person loses weight, regardless of the method, something called metabolic adaptation occurs where your body learns to use less energy because it's not getting as much fuel from food. So, in simple terms, metabolism slows down as more weight is lost.
I'm glad, Olivia, that you mentioned the claims data. So actually, we'll be talking about real-world adherence and persistence data in part 2 of our podcast. So, okay, we know that there are many underlying factors that can contribute to obesity, or to being overweight, right? Lifestyle and behavior are one part of all of that. And I'll try to paraphrase what you just said, Olivia, that GLP-1s, I think you said something like GLP-1s do not address the root cause of obesity, and that they're simply reducing hunger and appetite while patient is on the drug. So then I guess what's the role then of lifestyle and behavior and weight management? I'd love your perspective, especially with your background, in fitness and you being a personal trainer yourself.
I am really glad you asked this question, Miriam, because, I can't stress enough how important lifestyle and behavior changes are and how big of a role they should have in weight loss and weight management. If you look at any guideline, whether it's for obesity, diabetes, hypertension, really any chronic disease, it will likely mention a lifestyle component as a non negotiable cornerstone of management. So I think as these new weight loss medications are being adopted more and more, we really need to remember that these drugs should only serve as a supplement to lifestyle modification. And, when these drugs were studied in their clinical trials, they were only used in combination with a reduced calorie diet and increased physical activity. So, in order to produce weight loss, patients need to be in a calorie deficit where they're consuming fewer calories than they're burning. And what that looks like in most recommendations is going to be a calorie reduction of about 500 to 750 calories per day, with most calories coming from whole food sources like vegetables, fruits, whole grains, and lean proteins. And along with the diet component, patients also need to increase their physical activity. So the goal there is to aim for a minimum of 150 minutes of moderate intensity aerobic exercise per week, along with at least 2 or 3 resistance training sessions per week. And then what's also helpful for a lot of patients is a behavioral therapy piece where close monitoring with their provider is involved, along with continued education, and even a group component where patients are receiving support from others who are also trying to lose weight. And the lifestyle components will be key to help prevent weight rebound if a patient needs to discontinue their weight loss pharmacotherapy.
So it sounds like a key piece here is that while GLP-1s are certainly innovative, right? They should never be used in a silo. That lifestyle modification piece that you talked about needs to be made, excuse me, along with the use of the medications as well. So since there are many factors here to consider, what does appropriate patient selection look like? If I'm a payer listening, I think this one's going to be of interest.
Yes, this is an important question because it's so crucial to make sure that each patient is a good candidate for weight loss pharmacotherapy. And a and patient selection does really need to be individualized. So I think that's a key word that I'll keep coming back to. So the main item that can be used as a tool to assess this, as discussed in the guidelines and in product labeling, is the body mass index or BMI. So, for most weight loss drugs, including the GLP-1s, a patient may be eligible for therapy if they have a BMI of 30 or higher, because that's where you get into the obese category. And then certain patients who are considered to be overweight with a BMI of 27 or higher can also qualify if they have at least one weight related comorbidity. So, something like diabetes, hypertension, or dyslipidemia. Now, I do want to point out that the BMI has limitations. So, this is where that individual patient assessment is so important. So, just to give an example, you might have a patient with a BMI of 27, but maybe in visually assessing them, you might notice that they do have a lot of muscle on their frame. And since muscle is denser than fat, the patient might not actually need to lose weight. They might just be muscular. So you might want to reconsider pharmacotherapy for that type of patient. Or maybe you have a patient with a BMI of 27 who actually does need to lose weight, but maybe they have not attempted any lifestyle changes whatsoever. So that patient might be able to lose weight pretty easily by just making a couple small dietary changes, and you might not have to jump straight to pharmacotherapy. So again, it really should be individualized, and we need to remember to assess the whole patient and not just go off of that one BMI number. But then also beyond that, I think it's important to keep in mind that the GLP-1s are just one class of weight loss drug, and there are other options available. So there will be patients with certain comorbidities that won't be a good candidate for a GLP-1, like if they have a history of thyroid cancer, for example, or if they have gastroparesis. We need to make sure we are assessing for appropriateness. And I'll also just mention that choice of pharmacotherapy should be based on patient preference as well. And I think it's really important to have conversations with patients to go over all of their options and really involve the patient in these decisions.
Olivia, what I'm hearing you say is this concept of shared clinical decision making, basically between the patient and the provider, and how key that is. And I guess it's important to manage patients' expectations, remind patients that these drugs are not a magic bullet on their own, right? And they do need to also have the lifestyle piece on board. So, really, that holistic, individualized approach, I think, is what you said. All right. So, are there any guideline recommendations then from professional societies to help guide appropriate patient selection?
Yes. So we do have some guidelines that are relatively older from a couple of different organizations, and they don't cover the use of GLP-1s for weight loss in very much detail. So I'm not going to focus on those. But we do have newer guidelines from the American Gastroenterological Association, or the AGA. So they published an obesity guideline in 2022. And that guideline specifically suggests Wegovy at its highest dose, which is 2.4 milligrams weekly, as a preferred medication option because of its overall magnitude of benefit. Now, the guideline also includes Saxenda at its highest dose of 3 milligrams daily as a suggested option as well. And I also do want to mention that the Endocrine Society guideline is in queue for an update. And also, the AACE is currently updating their obesity algorithm.
Good to know. We will certainly be watching for new updates there. Okay, so I'd like to switch gears to pipeline, a topic that's top of mind for payers, and learn about what's coming. Carole, you have expertise in the pipeline area. If you could, maybe let's start with Zepbound. What other uses is it being studied for?
Well, Maryam, there are additional phase 3 trials for weight loss for Zepbound, and they include the Surmount Maintain trial. And this trial could provide some answers on whether a lower dose, say of 5 milligrams, may be a strategy for the maintenance phase of weight management with these agents. And the Surmount Adolescent trial is looking at Zepbound in those 12 to 17 years of age. And this study could put Zepbound on par with Wegovy and Saxenda regarding age, since both of these agents, Wegovy and Saxenda, are indicated in this population.
So, what about investigational drugs for weight loss? Zepbound is FDA approved, but being studied for other uses. What other agents are being studied here?
Well, there are 5 additional agents that target GLP-1, and they're in phase 3 trials for weight loss. Among them are 2 single action agents that target GLP-1 only. And one of them is oral semaglutide by Novo Nordisk. And as Olivia mentioned earlier, oral semaglutide is currently approved as brand Rybelsus, and it's indicated for type 2 diabetes in adults. And the dose for type 2 diabetes is a daily dose of 7 milligrams or 14 milligrams. But then there's the Oasis 1 trial that's looking at a 50 milligram dose of the oral drug in adults without diabetes. And published data for this study reported a 15.1% mean reduction in body weight after 68 weeks on the medication. And then there's the Oasis 4 trial, which is evaluating a lower dose for weight loss, again, in adults without type 2 diabetes. And I'd like to add here that earlier this year, Novo Nordisk indicated that they plan to file for approval for oral semaglutide for weight management. So we'll be watching for this in the coming months.
Certainly. And you mentioned oral agents, right? So are there any other oral GLP-1s that are being studied for obesity?
Well, yes. In fact, Eli Lilly is evaluating oral orforglipron, and this agent is a non-peptide GLP-1 receptor agonist, and it's taken once daily. And it's being studied in the ATTAIN-1 and ATTAIN-2 trial in non-diabetic and diabetic adults, respectively.
Got it. So earlier on, Olivia talked about the gut peptide or hormone. I guess what's the significance then of orforglipron being a non-peptide, Carol?
This is an important point. The currently available GLP-1 receptor agonists are peptides, with most requiring a sub-Q administration. And it's been a challenge to develop oral bioavailable formulations, but Novo Nordisk was able to overcome this challenge with oral semaglutide by formulating it with a permeation enhancer. But the interesting thing about orforglipron is that it's a non-peptide GLP-1, and being a small molecule, it allows it to be orally bioavailable without the need for a permeation enhancer.
That's really interesting. Well, we'll certainly keep our eye out on this one. So let's see, what other agents are in the pipeline? Are they all targeting GLP-1 or perhaps GIP like Zepbound does?
Well, there are some other agents in the pipeline that use other mechanisms in addition to GLP-1 agonism to produce their weight loss. Novo Nordisk has paired the GLP-1 agent semaglutide with the amylin analog congrilantide, and the combination is administered via once-weekly sub-Q injection. And it's being studied in the REDEFINE-1 trial in patients without diabetes, and then in the REDEFINE-2 trial in those with type 2 diabetes. And then another dual-action product is survodutide, and this is by Boehringer Ingelheim. And like the other, it's administered once weekly via sub-Q injection. But this drug activates both GLP-1 and glucagon receptors. And it's being studied in the Synchronized-1 and Synchronized-2 trials in adults with obesity or overweight. And the Synchronized-2 trial enrolls participants who also have type 2 diabetes.
I see. So we have oral agents, right? We have dual acting targets as well. What else is being studied in the pipeline?
Well, there is one triple action agent in phase 3 trials, and this is retatrutide by Eli Lilly, and it targets GLP-1, GIP, and also glucagon. And it's also administered sub-Q once weekly. But it's being studied in the TRIUMPH program, which is evaluating the drug in non-diabetic and diabetic adults. But this program is also studying it in adults with severe obesity, being a BMI of at least 35. And these patients also have established cardiovascular disease.
Okay, so you mentioned retatrutide has a triple target, right? You said GLP, GIP, and glucagon. Does this translate into higher efficacy?
Well, there is a published phase 2 trial for retatrutide, and it reported a 24.2% reduction in weight loss after 48 weeks. And this data suggests that retatrutide could provide the most weight loss of agents discussed today. However, the study was small, and it needs to be confirmed with a larger phase 3 trial.
Got it. So what about the SELECT cardiovascular outcome study with Wegovy? I'm curious, do we know when Wegovy is expected to get that in their label?
Well, we do have some idea. Based on the SELECT trial, Novo Nordisk did submit an application to the FDA for Wegovy for an indication for risk reduction of major adverse CV events, or MACE, in patients with obesity or overweight. And a decision for this is expected sometime in 2024.
And what about Zepbound? Is it also being studied for cardiovascular outcomes? Do you know?
Yes, it is. The SURMOUNT-MMO trial. And this is evaluating cardiovascular outcomes for Zepbound in adults with obesity. It's enrolling adults with and without established CVD. So it will evaluate both secondary and primary prevention But the data is a ways off. It's expected in late 2027. And here, I'd also like to mention that there are two dual action agents, survodutide and semaglutide plus cagrilintide. These agents have already started their CVO trials, and data for these is about 2 to 3 years away.
All right, so we talked about the pipeline for weight loss. Are any of the GLP-1s being studied for other indications? I suppose what I'm thinking here, Carole, is weight loss, not non-weight loss indications.
Well, there are weight-related indications, and these include conditions such as heart failure with preserved ejection fraction. And actually, Novo Nordisk may actually file for a label update for Wegovy for this indication in the first half of 2024. And then there's other weight-related conditions that are being studied, such as type 2 diabetes and obstructive sleep apnea, also polycystic ovarian syndrome. And then there's also phase 2 trials for patients with non-alcoholic steatohepatitis, or NASH, which is heavily associated with weight. But for these indications, we are a ways out from FDA filing and approval.
Well, that pipeline landscape is certainly dynamic, and we have a lot that we are monitoring on our radar. Now, let's spend some time on drug shortages, an issue that impacts everyone, really. Unfortunately, there continues to be many shortages in the US. Most recently, like we've been following drug shortages we've been looking at RSV, drugs for ADHD, of course, the GLP-1s as well. What's the impact of supply chain on GLP-1 access? Carole?
Well, Maryam, I'm glad you mentioned this. Saxenda and some doses of Wegovy and Ozempic are in limited supply, and this is due to a demand, increase in demand for the drugs. And Mounjaro also had some previous back orders, but currently the manufacturer is not reporting any shortages. But, this is important because a lack of supply of these GLP-1 agents that are indicated for patients with type 2 diabetes could result in negative consequences for this population. And as a result, the shortage of Ozempic, healthcare providers have been asked to hold off on starting new patients on the drug. And in addition, patients already on the drug may need to change their drug to another GLP-1, and this may mean use of a non-formulary product and the need for prior authorization.
So, in light of these supply chain issues and high cost as well, are patients using any alternative means to get these medications?
Yes, they are. Patients are seeking GLP-1 agents at online clinics and medical spas, and they're also looking to compounded versions. And we know that the FDA has received reports of adverse events related to the use of compounded semaglutide. These products contained impurities or salt forms of the drug that did differ from the approved products, and they hadn't been shown to be safe and effective. But manufacturers are taking steps to meet current and future supply demand. Novo Nordisk announced that they will be expanding their production facilities. And Eli Lilly already doubled its production of incretin agents back in November of 2022.
Interestingly, Carole, the social media piece has fueled some of the supply chain pieces that you just talked about. So that's a great segue into understanding what role social media plays in this GLP-1 craze. Olivia, any thoughts there?
Yes, absolutely, Miriam. So I think social media has played a huge role in this boom we've seen in interest in GLP-1s. And we've seen this particularly for Ozempic. And a lot of that is because of celebrities and other social media influencers who have shared pretty dramatic weight loss results from its use. And they're sharing on platforms like TikTok, Instagram, Facebook, you name it. And it's interesting too because Ozempic, as we've covered, is not approved for weight management. It's only approved for diabetes. And this brings up a whole other issue that we won't get into too much today, but we are seeing this off-label prescribing of these drugs, particularly Ozempic, because of this social media use. And this relates directly back to the supply chain issues that Carole just discussed. But I do think from the healthcare side of things, it's important that we all make sure that accurate and truthful information is being shared online about the GLP-1s, because it really is our responsibility to make sure that these drugs are being used appropriately.
This social media piece reminds me of some of the mis and disinformation, I would say, that we saw with the COVID-19 pandemic and now with GLP-1s, but a topic for another day. So, as we start to wrap up here, ladies, I'd love to hear your thoughts on what you are hopeful about for the future of GLP-1s and chronic weight management. Olivia?
This is a great question, Miriam. I think, first of all, the recent popularity of the GLP-1s for weight loss really creates learning opportunities for the medical community as a whole. There's still a lot we don't know about these drugs, including long-term efficacy and safety. So I'm looking forward to more real-world experience with these drugs. And pharmacy organizations will play a pivotal role in staying on top of emerging data and providing education and evidence-based information to not only prescribers, but also patients. And I also hope that we can find ways to overcome some of the barriers to long term adherence to these therapies. So, we talked earlier about how patients often don't continue on a GLP-1 for more than a year. So, it's important that pharmacy organizations explore the reasons for that and then work to overcome barriers, which may include cost and also tolerability of these agents. And for me personally, I'm really excited about the recent emphasis on weight management that GLP-1s have brought. And I hope that they continue to bring attention to this space so that as a collective, we can continue to work on tackling the obesity epidemic.
Yes, and I'll just add that, I think by providing real world data, pharmacy organizations can improve weight loss outcomes. These organizations can also provide programs to help support patients in their weight loss journey and, so that the patient can safely and sustainably achieve their goals. And I'm also interested in what's in the pipeline for weight loss and weight-related conditions, particularly the non-peptide GLP-1s as oral options. And will any of these GLP-1s prove beneficial in patients with NASH, which is a weight-related condition that currently has few options for treatment?
Well, Olivia and Carole, it has been a pleasure talking to you both. I'm grateful to have you join me. Thank you for your time, the clinical pearls, and the informative dialogue. It's been really fascinating.
Miriam, thank you for this opportunity to discuss such an important topic. I really enjoyed our conversation, and I hope it was helpful for our listeners.
Yes, Maryam, thank you. It's been such a pleasure to be part of this important discussion.
Thank you to all of our listeners for joining us. I look forward to having you join part 2 of our GLP-1 podcast, as well as future podcasts. Thank you so much.
Thanks for joining us for this episode of Pharmacy Friends. In part 2 of the Skinny on GLP-1s, Maryam talks about how real-world analysis of GLP-1 drugs for weight loss finds low adherence and increased cost in the first year, with industry veterans David Lassen, Prime's Chief Clinical Officer, and Pat Gleason, Assistant Vice President of Prime Magellan Rx's Health Outcomes Team. Want more insights about the latest trends? Subscribe to our Pharmacy Friends podcast.